All right, good morning. How is everybody today? Wait, terrific. My name is Brent Stackhouse. I run the venture fund at Mount Sinai Hospital in New York City, and it is such a pleasure to be joining everyone here at RESI. Once again, another JP Morgan, another RESI, another 20-minute wait for the elevator, but we all made it. I'm really excited to have everybody here. We have a really impressive panel today. I am so humbled to be joined by such incredible professionals, and we've actually been practicing this. This is not our first time doing this. It's going to be great. I'm really curious from the audience, who here is an investor? Oh, wow. Okay, and who here is an entrepreneur that's raising money? And who here is an entrepreneur looking for business with the hospital system? And who here is a journalist? Oh, thank God. Okay. I support freedom of speech, but not when I'm talking. So I'd like to take a couple minutes here and introduce the panel. Our goal today is to give you guys tips and tricks on how to work with hospitals that are making investments in companies. And my biggest takeaway for everyone here today is to understand that we all have a very different take on the business. So we're actually seated in order of sort of the spectrum of how health systems have structured their investment strategies. I hope you find that helpful. I know it's how I think of the world. Mount Sinai is an $8 billion health system. We have 8 hospitals across the metropolitan New York area. Mount Sinai Ventures was started about 10 years ago. We invest seed, early stage, latest in Series A, average investment size is about $500,000. And we have about 22 investments to date. I'd like to introduce Ann Wellington with Cedars-Sinai. Ann, if you could give us background on what your program is at Cedars.
Thank you. Hi, I'm Ann Wellington. I'm the Managing Director at the Cedars-Sinai Accelerator. So my program, we work with early stage companies that are looking to partner with the hospital system and have the opportunity to learn from the experts and leadership at Cedars-Sinai. So we bring in about 10 companies at a time to spend 3 months with us in Los Angeles. We're the Los Angeles Sinai, the Mount Sinai sort of lesser cousin on the coast. We're more laid back. We surf and stuff. So we're the Los Angeles Cedars-Sinai, and we bring in 10 companies at a time for about 3 months to work closely with them. The accelerator hopefully accelerates their progress in developing the products that they're working on and getting those into the markets, and most importantly into the hands of our providers and our patients, so helping to improve care. We primarily focus in the digital health and healthcare IT areas, so most of our companies that we work with through the accelerator have a software component. Some are hardware-enabled software, software-enabled hardware, and others are just pure software. We don't do any sort of biotech, therapeutics, pharma-type work through the accelerator, and we also don't do purely consumer-focused applications or devices. In terms of investment, we do a $100,000 investment in each company that comes through the accelerator program. That's in the form of a convertible note, so the amount of equity we get in each company varies a little bit. We don't take any equity, sort of a flat rate just for participation. We also have a venture fund that if we're doing follow-on investments in some of the companies that come through the program, we can do more significant investment in addition to that $100,000. We've had 47 companies come through our accelerator program. We're using about a dozen of those that have sort of commercial contracts to be used widely at our health system, and then about a half dozen that we've done additional follow-on investments in. And the venture fund has done some additional investment for a little bit later stage companies that didn't go through the accelerator. So I'm focused mostly in the seed A and a little bit into B through the venture fund, but my role is very much focused on those seed and Series A companies.
Awesome. Thank you.
Good morning, everybody. Brent, thank you so much, and thanks to RESI for the opportunity to share more about what we do at Jefferson. So I'm Raj Agarwal. I'm at Jefferson Health System. It's a regional system of scale in Philadelphia. It's grown in the last 6 years from being a 3-hospital, $1.5 billion revenue health system to now 14 hospitals, about $5 billion in revenue. We're executing on a couple of other acquisitions, a cancer center, Fox Chase, Einstein Health System, and also purchasing a health plan of about 300,000 Medicare, Medicaid beneficiaries. And so we'll be about a $9 billion health system by the end of the year with about 20 hospitals. What I do is I leverage that living laboratory to work with external companies, mostly early stage seed Series A companies. And what we do is we don't invest directly in the company as our front foot forward. We really do all the due diligence on the companies, and then what we do is leverage the living laboratory of the health system, so to co-develop the technology, so make it fit for purpose, work with our experts on the front line, and then we deploy it in a pilot sense within a part of Jefferson. So that might be 3 hospitals, 5 primary care sites, urgent care sites, whatever is the right thing to do. And then we'll validate that technology based on 3 metrics: clinical, operational, financial. If everything goes well, up to that point, what we do is we invest. So it's on my dollar that everything we do at Jefferson, it's on the dollar of the company that everything that the company does. So this isn't a transaction, this isn't sponsored research. And so we put risk up front, and then if everything goes well, what we do is 2 things. One is that we become an enterprise-wide customer of the company, because if it's worked in 3 hospitals and we want to take it to all 20. So we become the first major enterprise-wide customer for the company. And then the second thing is we leverage that to then go on the road, metaphorically and in reality, to other health systems and say, hey, look, this is what we've done, are you interested? The business model that underpins this is that we'll take a sweat equity investment, we'll take a revenue share, we'll take options warrants. We've looked at 300 companies in 2.5 years. I was recruited by our CEO to start this office up 2.5 years ago. We've signed deals with, I think, about 14, 15 companies right now. We've focused on digital health, health IT, process innovation, telemedicine, but we're also opportunistic. One of our, probably our biggest success right now is a hemp company that's producing hemp-based materials, and we invested $5 million of sweat equity in that company. The company is now publicly traded and worth $1 billion, and we probably own about a 10x multiple of that company right now. So that was a completely out there, opportunistic, before the Farm Bill came out.
You did that in 2.5 years.
Yeah, we took a huge risk, it was a very creative deal structure that we did that with. So that's what we do, and we do, out of the 14 companies we have right now, we've invested in 2 of them. One $500,000, another $1 million, but that's not our front foot forward. We just do that because it's a really, really smart thing to do. And I think as we progress over the next 2.5 years, we will start investing more cash in the companies. But when I started, I said to Steve Klasko, our CEO, I said, look, don't let's just have fun like everyone else, right? Let's actually show the value of the living laboratory. Let's actually do the hard work, which is really, really hard, and then let's do the follow-on investing. So that's our model. Thank you.
Thank you, Jeff. Neil, tell us what's going on.
Good morning. I'm Neil Malaya. I'm Managing Director with University Hospitals Ventures. University Hospitals is a $4 billion regional hospital system in the Cleveland area. We have 18 hospitals over 12 counties. It includes very urban, suburban, and very rural communities, so we have a very mixed population that we serve. We also have, I think it's now the 6th or 7th largest ACO that's part of our group. University Hospitals Ventures was stood up about 2 years ago. I've been there about a year. And it's a slightly different model than some other organizations. We have our inside out, our technology transfer. We also have a development fund on an annual basis. We'll deploy about $150,000 against 7 or 8 projects. And from inside out to help reduce risk and move them forward so that they're more investable for us and for others. We have an active outside-in program. We have partnerships with Plug and Play, who many of you know, the accelerator out here. We have a partnership with Avia, the healthcare investing network that focuses on digital health solutions. It's about 50 hospital systems that we're part of. And we actively leverage our network of friends like here on the panel to source deals, knowing that while we have a lot of smart people inventing a lot of great solutions to our problems, not all of those solutions are best in class. So we're really looking for best in class solutions from the outside. In addition, we have an internal consulting group that's now started to do external consulting. They are focused on human-centered design. This includes people from places like IDEO, who really focus on the customer and the customer need. And so we've done quite a bit of work on journey mapping and, like many of the systems, focusing on access and the patient experience. So we have a heavy focus on those sorts of opportunities, in particular from the outside. The healthcare IT has been our primary focus, although it's not all we do. In addition, and I think what makes us unique compared to some of the other systems, under the UH Ventures banner, we have some core adjacencies. So things like specialty pharmacy, we started instead of, and that's grown into tens of millions of dollars of revenue. The accretive revenue goes to actually support our commercialization activities, knowing that licensing and venturing is not something that's going to generate revenue in a year or two. Unless we are smart like Raj, and they really good bets like that, which
There's a big team.
which we like to do. So we've got the luxury of pharmacy, home care, lab services. So we've got these operating businesses as well that we're sourcing opportunities to help grow and create efficiencies for. Sitting over the top of it all, we do have an evergreen fund. We can deploy up to $1 million in any particular investment without having to jump through hoops and going through finance committees. We can deploy more capital than that, but it does take a little bit more tenuous process to do that, but we do have the ability to deploy larger amounts of capital. We've got 5 companies in our portfolio now. We've tended to invest $250,000 to $500,000 in reserve, more for follow-on rounds. We've invested seed, Series A, and actually our first investment was a Series B investment. Like Jefferson, we'll only invest in outside opportunities if there is an opportunity to strategically partner, whether it's piloting a technology, participating in a clinical trial, or in that case, they had a product ready, in the Series B case, they had a product ready that we became a customer of. So we have to have that strategic tie, and we also believe in the living lab approach where we can add value, and as investors, we think it helps us better understand the opportunity. Every investor makes customer calls. We call people down the hall and ask them what they think. And we also think that we can add value to our portfolio companies by accelerating their commercialization process and bringing them through and being reference sites.
All right, Rich,
yeah, I'll be brief so we can get into the real questions. So Richard Crosha, I represent Providence Ventures. We're a little bit bigger than some of these other health systems. I think often quoted as the 3rd largest health system in the country. I think Common Spirit might have changed that, but it doesn't have the same cachet as 3 of you say 4. The Providence Ventures team has $300 million under management across 2 funds. We operate very much like a traditional fund with one strategic LP that we work very closely with. Similar methods, we use the LP to create strategic relationships with most of our portfolio companies. One thing we're very proud of is, we are 16 for 16, so every company we've invested in has gone on to work with the health system in a very strategic, intimate way. Something we're very proud of as a team. As part of Providence, our team is a subgroup of a larger digital innovation group that I would be remiss if I didn't mention. They have taken a very sophisticated build-by-partner approach to innovation. So we have a very sophisticated innovation model where they're kind of identifying problems from health system executives, our doctors, our physicians, our nurses, kind of boiling those up to problem statements, and then working with the ventures team to say, hey, are there any companies you're seeing in the space that are addressing these problems? If not, then they go and build it. So we also have a team of about 200 engineers that are building products, services, mostly on the digital side, and then spinning them out. So Zelf is a really good example of one of those companies, as well as Circle, which was acquired by Wildflower. So yeah, that's Providence.
So Rich, clarify for me, you have Providence, St. Joe's, Swedish, all these hospitals within your health system. Are they all limited partners in the fund?
So those are all wholly owned by Providence, so it all kind of boils down to one corporate balance sheet. And we are getting our allocation from the larger corporate balance sheet. So it's not individual allocations from each of those health systems, but we work very closely with all of our regional partners. It's just one big health system, and unfortunately, or one big health system. We actually are going through a rebrand. So a lot of things. I think that was announced. Maybe but so we were, like most health systems in this country, we grew through inorganic M&A, mergers and acquisitions, combination of a lot of not-for-profit, faith-based, but Swedish isn't faith-based health system, and through that we've been able to retain the brands in those geographies because there's a lot of value in people know Covenant in Texas, they don't necessarily know Providence up in the Pacific Northwest or even Swedish. So we want to make sure that we're not getting rid of that asset that we're building in terms of the brand loyalty. But over time, I think we're going to transition so that we are more recognized on a national basis under the name Providence, so that people are confused. Yeah.
Well, everyone in the audience acts surprised when you get the announcement. So, what we tried to do with the panel in terms of how we're seated for everyone in the audience here, from right to left, or right to left. Providence Ventures is set up where they are running investments like a traditional institutional investor, but they have relationships with the strategic that they're then, it sounds like, placing 100% of the time.
So far.
So far. I was going to say Cleveland, I apologize. University in Cleveland has a standalone fund where they're making investments with a single LP. It's intimately linked to the health system. And then Rajesh Jefferson is making sort of sweat equity investments and then occasionally follow on. But that's investments off the balance sheet. That's how Mount Sinai is structured. We're investing off the balance sheet. And then at Cedars, it's an incubator. They're not necessarily making investments, but as a part of the incubation program, there's $100,000. It's a part of that. And then if things do mature, what was it called? Exhumation. That's 2 years ago.
Now we're just Cedars-Sinai Health Ventures.
Cedars-Sinai Health Ventures will then do the follow-on investment. So the structure is somewhat different. I think the experience working with each of us would be somewhat different. So I think it's important for all of you who are trying to navigate these health systems. I'm out of curiosity of the audience, of those who are investors in the room, who's raising money for your fund right now? None of you. Well, I won't ask the follow-up question then. Okay. I was going to say, which of you make investments as an LP in funds, but they don't care. What's going on? We can. Okay, he wants your money. Who here invests as a limited partner in outside funds? I don't. Do you? Rich?
Our team does not, but our treasury team does.
Our treasury team
there are
does
a variety of funds that we're very closely linked with. Some of them also have healthcare strategies that we share a lot of deals with. They're definitely investing at different stages and sizes than Providence Ventures because it would be pointless to pay 2 and 20 on things that we're already looking at. But we do have a.
Does your treasury department return your phone calls?
They do. Oh, yeah. They ask us to.
Not mine.
We're the same. We do not do direct investing ourselves in other funds, but Treasury does.
Yeah.
And they do.
Yeah, same.
Yeah. So if you're looking to raise money for your fund, you're wasting your time talking to us. All right. So for the entrepreneurs in the room, I'm really curious. What are you guys looking for? What is a hot theme right now? What are you excited about in 2020? What do you want to put your money in? Is it cybersecurity? Is it AI? Is it any number of buzzwords? I know a lot of countries in San Francisco today and not here. Rajesh, what are you looking for?
I'm looking for a good partnership, a great partnership. It's the people.
The people.
Right? That's what I'm looking
for.
I'm looking for the right type of people that I want to work with, and then I can match them up with the right people within my health system. If it's something in epilepsy, something in asthma, something in, whatever, right? That it's a fit. And, fit is a very kind of all or nothing word, but that is really what I look for in the stuff that we've been successful on. Yes, we look at telemedicine and whatever else, AI and all that kind of stuff. At the end of the day, it's about building that relationship. Meeting with a bunch of companies this morning and so forth. And it's that initial date.
Yeah.
And then
what are you looking for? When you meet an entrepreneur, what skills, what experience, what je ne sais quoi are you looking for them to have?
The pedigree, the background, and the...
So exclusively management consultants.
and then I would say the lack of arrogance, because we don't have arrogance either, that they still need to develop their technology to actually make it fit for purpose, and they need to partner rather than we're just trying to sell you something, right? We know everything that works, and we just need Jefferson, we just need the brand to then be able to scale. And similarly, we are not arrogant to say, look, if it's something in, let me just give you an example, pediatrics. Why would anyone want to come and partner with Jefferson on pediatrics when you've got CHOP down the street, right? Okay? Just doesn't make sense, unless it's something so niche that we do that CHOP doesn't do, which is highly unlikely, right? And so we've got to be able to execute on that, and within our clinical pillar to be able to do that. So the lack of arrogance in the development of actually a real partnership where we have win-win approach, this is what we bring, this is what they need, and how do we make that happen together?
I'll echo we hear from a lot of startups that say they want to partner with a health system, but some of them really mean the partnership is just you give us money for the product we already have and we change nothing. So truly we want to partner in a way that involves, hey, we're really going to work together on this, we're going to learn from you, you're probably going to learn a lot from us, and we want startups that are coming in with an open mind, with curiosity, with an understanding of what they don't know and a willingness to acknowledge that, because especially when we're working with startups that come in and say like, well, I mean, we already have 2 hospital customers, so I think we've got it pretty much figured out. That is not appealing for us to work with. Companies that come in and say, hey, we think we know A and B, but we don't know C, D, E, and F. Can you help us with that? That's really appealing for us to say like, yes, we can dig in on that together.
So I have a question. So you would never invest in a first-time entrepreneur?
No, I didn't say that. No.
Okay. I heard you looking for experienced entrepreneurs.
Well, I mean, it depends. Experience comes in very different ways, right? They don't need to have been a CEO of a company to get experience, right? Yeah. I've never run my own company, right? You know, I'm a simple GI surgeon, right?
Any number of punchlines on it. All right, so when the CEO calls you and says, I saw this guy, he came to me, it's a great company, you gotta look at it. Is that great or the greatest introduction? Rich, how many of those calls do you get?
And so this is the third corporate strategic venture fund that I've worked for, and you see a variety of different CEOs, that treat the fund from a big shiny object to actually part of their long-term corporate strategy. The ones that do the latter, I think, are much more proactive, and they also don't get bogged down with trends. They focus on the big, hairy problems that we can't really solve as a health system, and that's really where we're going to be getting external innovation. If it's something that we can easily, take the resources we have and just apply a new business model to, it's going to be far cheaper for us to do it internally than to work with someone externally and pay what's probably a very high valuation. Sorry.
So an entrepreneur is able to do an end run.
It's a good introduction in terms of if you somehow track down one of our executives at a conference, give him your business card, he will send us that lead. If you send him a message on LinkedIn, they'll eventually get around to it. Or he should, depending on all the executives will, and it'll eventually end up in our inboxes. So that'll happen, but it's not. Unless you overly impress them, it's not really all that tangible in terms of what next steps look like. They'll usually say, hey, talk to the manager's guy, and then go from there.
Yeah. Let me just tell you that. I'm going to be really blunt. This. My CEO, Steve Klass, goes on stage every week, right? And 50 people come up to him after every talk and say, here's my card, whatever. That gets forwarded to me, and the email from the guy is, Steve loves it, right? Steve loves everything. That's his job, right? He's forward-facing. He loves everything. So if you have to lead with Steve loves it, I'm afraid you're already fighting a losing battle. Tell me what you actually do. Tell me how you want to partner. And Steve's so far away from this, right? I'm the one that's going to have to run the balance sheet and make this work. And yes, we'll get Steve. Steve's one of my mentors said, Steve's the opener and he's the closer, right? Everything else is me and my team.
I like that. So I am not, again, just to jump in here real quick, I am not the gateway for innovation from outside our health system. I am not the one pairing you up and making introductions with people within my institution. I am going to my subject matter experts within my institution and asking them, what are you using? What are you excited about right now? What are you seeing that you're playing around that you think is going to change medicine? They're the ones who are saying to me, I think this thing's exciting. So they've already done that pairing. Part of the reason it's exciting to all of Mount Sinai Ventures, there is no team. And I tried when I got there to do that work. It takes like 18 months to get someone to look at something, vet it, give you feedback on it, get back to me. That's it. They will take my phone call and explain what venture investing is. It's a very, very long process. What I found was we have 3,500 doctors, 14,000 employees. There's a lot of stuff people are using already. I can pick from that and save myself the anguish and also have more likely chance of hitting during the fundraising cycle than if I'm out there trying to bring self in and convince our CMO that sells the bee's knees, which is,
We've actually taken an approach. We're going out to our clinicians and our the administrators and saying, what problems do you have? And we're going out to our partners, the plug and plays and the obvious. based on the problems we have, looking for solutions. So we're trying to flip it. It's a fairly new thing for us. It used to be that the CEO or some of the C-suite would call and say, I met this person. And we, of course, would take the meeting. And if they were good, we would continue. But more often than not, it was just, we didn't have a solution to a problem that we had. So we're really trying to drive down to our problems and back in and search the network for best-in-class solutions.
It's not always that they're not problems, but for a health system with limited resources, it's where does it fall on the CFO's list of something we want to prioritize to address, and if it's not towards the top of that list, we just can't, we're trying to tack through these 30 other things that are rolling to the top because they're much more important and pressing for a health system. And I think it's important that you're addressing those versus something that's maybe a very novel solution and saving margin down here, but if it's not these big hairy problems up here, we probably won't be focusing on that.
So can I actually ask a question?
Can I just give one piece of advice related to this? I think for any entrepreneur looking to get connected into a health system, if they steer you to a front door that they say, this is how we want to engage, doing an end run around that is usually a waste of your time. Not because I don't get upset if people want to try and go around and say I'll try to get connected to these doctors, but it just lands back on my desk a month later, and then you've spent a lot of time trying to find the right person and do a lot of sort of strategic back channeling, and with the same end results. So I would say check and just say, how do you try to engage with these companies, and if they give you an answer, trust that, because it'll be the best use of your time.
I'm actually just going to comment on that. So there's a handful of companies we've looked at where over 2 years they have literally gone to 7 different units within Jefferson, right? Yeah. And then we look at the company and they finally come to me. I'm like, yeah, I'll introduce you to our CMO, I'll introduce you to our CFO, this person. And then I send out an email to all these people like, oh yeah, we saw these guys in February, we saw these guys in August and so forth. And that's just disingenuous, right? So just be upfront, and then, if it's a no, for whatever reason from Jefferson Strategic Ventures, right, then don't try and go around. The worst thing is don't then try and get Steve Klasko and say, oh, Steve loves it, right? Okay, great, okay. Now it's just wasting everyone's time, right? Okay, just be really upfront. The question I wanted to ask, which was based on a bit of the discussion earlier, was how, when I look at a lot of technology and I'm like, oh my God, this is really, really terrific. I'm a clinician scientist, I kind of know the field and so forth, right? And then how do I work with the company to actually get my clinical pillar engaged into this? Like you said, what are the top 3 things, right? And those top 3 things are always changing, and their job is to keep the lights on and keep the wheels running, right? So how do other people empower? I'm just gonna, the way I do it is I just use a lot of muscle and a lot of sweat and a lot of grease to try to get this stuff done, and I don't know if there's a strategic way to do that with the companies.
One of the things we've been doing is through some of these partnerships, we'll have a problem statement, maybe it's access, and they'll bring 10 companies in, and we'll bring a panel, we'll organize a group of people to come in and listen, and then we'll gather afterwards and say, so what did you think, what did you think, what did you think, what did you like, would you be willing to spend your time engaging with this company? How would that help us? And try to drive to the economic or other clinical benefits that might accrue, but we'll try to bring a group of companies in an area and have a group of our physicians with relevant background or who would be the key customers and have them help us vet.
We do the same, very similar process of through our accelerator program. I review applications, and me and my team, we narrow them down to about a top 50, and then bring those to our stakeholders. And to me, I don't want to be pushing. It's not my organizational role to push innovation, it's just to facilitate. So we put the solutions in front of our stakeholders, and if they're excited and sort of step up and say, this is solving a real problem that I'm facing, and I want to engage with this company with the idea that they will provide something useful to me, that's how we move forward. So they're really self-selecting it.
So we have a real challenge. I'm going to go to you, Rich, next. So we have a real challenge at Mount Sinai in that the way our physicians are compensated is for clinical time, administrative responsibilities, research, and teaching. And I show up and say, oh, we're going to make this investment. Can you help me increase the value of this investment by helping them iterate on their product or validate their product or going to conferences and talking about their product? And they say, yes, pay me. And I do, circuitously. So what we do at Mount Sinai when we go make an investment, let's say it's $500,000, I will then have a separate $100,000 set aside as approved by my board to go to the department that is relevant for that investment to offset the time of those people in that department. And that's how I guarantee that I can give my portfolio companies the love and attention that they deserve. The panel, do anything, do something similar, do anything, incent your stakeholders to participate. Rich,
defer to legal. No, I'm just kidding. Do not recall. We do not. So we think the incentive is there. We put a lot of. So I arrived for Fund 2. So Fund 1, there was a lot of pains of putting these processes in place that I didn't have to do. That I've done in other strategics that I've worked at. But here, we really have well-paved pathways where we are continuously educating all of our physician stakeholders and executives what it is that Providence Ventures can help you do, whether it be just a pulse on innovation, whether it be helping to find companies to address a specific problem. So they're coming to us with, hey, we have this problem, what are you seeing out there? And I think the incentive is we can really help relieve their headaches, we can reduce burnout, we can increase patient experiences and outcomes. And they know that because we have a proven track record. We're working with all 16 companies that are offering value that we track in terms of ROI that we were really trying to target with that specific investment. And now that we have that, but we're still continuously going to Southern California for St. Joe's. We're going up to Alaska in the middle of December to really just keep engaging. Not the best. Keep engaging with our stakeholders so they know that we're still here and we can still provide value, and they just keep coming to us with problems that we can really help address. And I think that's the incentive, is knowing that there is a solution to some of their problems and we can help with that.
So you have a culture of innovation that you play into.
Yeah, does that sound cheesier?
That's my words.
So we have not followed that path directly, although we're starting to do more outside consulting, bring companies in who may want us to look at a product or help them sort of define a solution statement, and those physicians do get paid. A nominal amount, but they do get paid. Where we've had some co-development opportunities, we've contemplated but have not gone down the path yet of accruing, and so the physicians will get paid by the department, and the department then wants to know how they may get reimbursed. So
that's how I structured mine.
So we've contemplated, but haven't gone down the path yet of having them sort of reimbursed out of revenue streams that might come in the future. But I like your model.
And I believe it was impossible to work with, and they approved it, which was shocking.
Wow.
Culture of innovation at Cedar Sinai?
I will talk about, I think there was a question. Was there a question?
And I'd like to answer your question as well, Brent.
Absolutely. So we're going to take Q&A in about 5 minutes, I think. Let's finish out on this, Rajesh.
Oh, sorry, you were on.
So yes, we have a wonderful culture of innovation at Cedars. So we have a very top-down sort of mandate that you wouldn't find anyone at Cedars. Hopefully, don't search LinkedIn because I might be wrong, but I don't think anyone at Cedars has innovation in their job title. So it's very clear sort of from the top down that innovation is everybody's responsibility. So we do not provide additional sort of compensation, and similarly to Providence, the incentive is that hopefully we're finding good enough solutions that people say, I want to engage with this because I see it being useful to me. And so like an example I'll give is, in our last class, we had a company that was focused on reducing physician documentation burden, and I had physicians like calling me to say, I heard you have a company working on this, I want to meet with them, I want to give them feedback, and that's the space we want to be in, where I'm not chasing people down to say, please meet with this company, but instead they're saying, this is awesome, let me meet with them.
That's an interesting company, by the way.
We like them.
Rajesh.
So, my job is, as I said earlier, is to find those amazing partnerships with the companies, and then what we're talking about is with my clinicians or on the academic side. And how I engage them is basically a study in human behavior, right? That's what we're trying to do here. So there is the model where, just like you said, Anne, there are people who are just so committed and over and above doing everything and working 70 hours a week, say, yes, I will do this, and they're a department chair or whatever, and I will do this because I really think that you're giving me access to pre-market technologies which I think can impact impact the care that I deliver within my division department for my patients. And I'm fully invested in that. And I'm going to get it all done, right?
I'll just clarify that it's not only the people who work 70 hours a week who are reaching out to me, but
Right.
similar.
But, you know, you want something done, give it to busy people, right? So that is one model, and we had an event last year where we had 130 of our innovation champions, which is what we called them, and celebrated them in the C-suite, and you know, it was wonderful. Like, thank you so much. Without you guys, we're nothing. We might as well close the shop. Now, as we're maturing, yes, people are asking to get paid for their time, right? So some of them, so we don't have a one-size-fits-all model. Some of them say, hey, look, you know, it's going to take me this amount of time, and we're investing that sweat equity, and then, you know, realize the upside. So we're paying them. The third model that I really want to work on, and we have one project that we're working on right now, is I've said, look, I can pay you to do this. I'll pay you 50K or 100K or whatever. But if you invest your own time, and however we monetize that, when I get my upside, which is a 3x upside, I'll give you a 2x upside on your investment. So basically, they become an LP out of my office. And I think that is really how we create a culture of innovation and say, look, I myself, as a department chair or a division, whatever, I'm investing my time because I see the upside. And it's diversifying the risk for us in terms of doing this. We have one tiny little deal that we've done.
Okay. So we're going to speed round here. There are a lot of investors in the room. I don't feel like we asked questions to the panel to feed the interest and curiosity of the investors in the room. So speed round here. Who here leads investment rounds?
We do.
Okay. And who here works with institutional investors with their portfolio companies? You get deals from institutional investors, or you bring deals to institutional investors? All right, I do as well. That is a huge part of my value proposition, is helping my portfolio companies fill out their rounds by working the phones and calling all the institutional investors I know. I find a lot of institutional investors are curious to hear what companies like ours are interested in investing in. We have another couple minutes before we start Q&A. I am very curious about a tweet that was out this past week from someone in the Twitterverse saying that hospital venture is fundamentally flawed. For those of you who didn't see this, don't worry about it. But for those of you who did, there were a couple different comments in the 14 points why we shouldn't be doing hospital-based venture that I was curious to get the panel's opinion on. One of them is that it is an ego project of the C-suite. Another was that CFOs are too busy trying to figure out how to keep the lights on to really work on corporate finance. So I'm curious for the panel, open season here, before we turn to Q&A. What were your thoughts on the tweet? How do you feel the health of hospital street ventures going, knowing that at least 3 hospital ventures shut down this past 2019? Rich, your thoughts?
I think ultimately our fund is a rounding error on the balance sheet. I'm just kidding. I mean, that's not been my experience with corporate innovation. I think there are maybe some institutions that do treat it as more flexible investing, like, oh, look how, the shiny stuff we're doing, we're in.
It's a PR play.
Yeah, it's a PR play. They're trying to get in TechCrunch or something. That's fundamentally not what we're doing. We're investing our time, but more importantly, our team's resources to identify companies that are solving really important problems for us that can help to improve our our economics, to improve the financial profile of the hospital, improve physician burnout, things like that, which will ultimately hit revenue or just ultimately hit revenue, I think, in my way, whether it's through patient outcomes or things like that. So I think it's fundamentally part of corporate strategy, and I don't really see it as a bright, shiny object, but it could be taken that way if it's not a very sophisticated manner. But no one on this panel is doing that.
I feel like if we're going to shut down funds that are started based on ego, health systems are not the place to start. Like, there's a lot of ego-driven investing out there in general. I feel like we're probably seeing a little bit of a correction in that several years ago, there was more and more hospitals realizing this is a great opportunity for us. We would like to get some return on investment for partnering with early stage companies. Hey, we should start a fund. So I think there's a little bit of a correction there of potentially some health systems that weren't properly structured and didn't have, to some of the points in that thread about making sure that they really understand the timelines and they really understand that this is not a 1 to 3 year ROI, this is longer term than that. So So I think there's a little bit of a correction, but I think it's too broad a brush to say there's been some that shut down and therefore all of them are broken and none will work. I think the health system funds serve a really important purpose, as we've talked about here, of being able to connect and provide some of that strategic guidance that wouldn't be available without partnering directly with a health system. So I think it fills a really valuable need, and even though some are shutting down, it's more of a correction rather than a sweeping condemnation of health system venture in general.
I'll leave it there. So we're going to open up the floor to Q&A. This gentleman here had his hand up earlier.
Yes.
Yes, sir.
How can each one of you describe how you engage with payers to be able to pull through and get paid, set up payment models?
Yep, oftentimes startup companies come to me and say, we have this great revenue model, just one day we're going to get a code and it's going to get reimbursed. And I say,
I've seen that same slide from multiple companies.
and I say, when that day comes, you call me.
That wasn't the question.
Oh, forgive me. So how do we work with payers?
How do you work with payers?
I
And
don't
how do
work
you-
with payers.
And how do you pull it through so you get through medical policy?
Medical policy review.
Yeah, so in a payer, in order to get set up so that you can get reimbursement and paid.
Right.
What's the process that you go through as you engage with a United, a Blue, in order to, how do you facilitate that process?
Right. So at Mount Sinai Ventures, if a company comes to me that requires reimbursement, where there isn't an existing code and there isn't payer reimbursement happening already in that space, and that is their sole revenue model, I will not invest, because it will be a cold day in hell before those claims are actually ever going to get paid. Even with something as simple as telehealth in New York State, the state announced we're paying for telehealth. None of the payers rolled out codes for another 2.5 years. And then when they did, they were a third of what everyone thought they were going to be. So I don't want to get burned on that. I don't invest in any company unless there's a very clear and existing revenue model.
Yes, that's to be an ROI for the health system, right? And so we don't work with payers, we're trying to do innovation projects, which probably are more kind of operational rather than true innovation that we're talking about here. And to be able to fix that, we're buying a health plan right now.
Do any of your health systems take risk?
So Providence does in a variety of different ways. So what's really unique about Providence is we're not just working with the health system. We have Providence Health Plan, it's a commercial payer, in the Pacific Northwest that also has some MA plans. We also own Care Oregon, so we bought Care Oregon, if you guys are familiar with that health plan.
So does that make it easier for you to get that
So
reimbursement?
it makes it easier to get reimbursement, but it's also, we're not just sourcing innovation for the health system, we're sourcing innovation for our partners on the health plan side. So if we see a company and the economic model, it makes more sense for the payers to be paying for this solution, whether it's usually more patient focused. Those are the individuals we're going and saying, hey, is this something you're into? Is this something that's addressing one of your problems? And then from there, we think about how do we work with the health system either to get that solution out there via our providers or through our digital experience, things like that. So it's a really nice test bed that we can go to. We think the easiest or lowest hanging fruit stakeholder would be to get something like that up and running in the Providence ecosystem.
And I will say something I've noticed among hospital-treated venture investors that's different than other corporate ventures. We're not patient. Like our hospitals need that return on investment immediately. I'm looking at a 24 to 36 month timeline for some sort of ROI.
We're patient.
She's really patient, which is why you told Otherwise, we're generally impatient, and so waiting around for FDA clearance or insurance reimbursement is kind of a non-starter for a lot of health system investors. Another question from the audience. Yes, ma'am.
So I actually showed up to this panel, and thank you very much for doing this. This is the first RESI panel that I've seen. Because when you're describing one's value proposition, there is either what will be reimbursable with a code or the money that we're saving the hospitals in. How do you look at monetizing cost savings from, I'm just making stuff up, frequent flyers
Yep.
versus a code?
So at Mount Sinai, so for the audience, the question was, how are we evaluating a company that's going to save money for the hospital system rather than yield a lot of revenue? At Mount Sinai Ventures, we don't invest in companies that are just saving the health system money. It's hard for that argument to actually really sail with most of our finance department. I'm curious, the panel, your guys' thoughts.
We've been trying to figure that out. I mean, we know that we need, we do have top line objectives, but we also have bottom line objectives. At the end of the day, healthcare systems really are focused on bottom line, and top line is only as good as it is to drive bottom line impact. So we're trying to figure out how we evaluate and accurately capture the value that's being created. And then the issue is, well, who is it accretive to within the organization? And that's where sometimes politics will get involved. And again, we're trying to work through, because as an organization, we need to justify why we're doing these investments and why we're doing these things. And we know that we can drive value to the bottom line. We're trying to figure out how we all acknowledge that value within the system.
Yeah, similarly, I would say it's not part of every problem statement that we're addressing, right? So sometimes cost savings isn't really a thesis we have on a specific thing. It really depends. So we're investors in Caris, if you guys are familiar with Caris. Obviously, they helped us remove FTEs or focus FTEs on higher value activities, which is obviously saving time. That's a very obvious cost saving opportunity. But with some of our other solutions, Zelda, for example, that's improving patient experience, which over time could hopefully lead to their writing reviews on Yelp or wherever. We're getting more exposure, we're getting more patients come through our doors, and that's more of a revenue opportunity if you kind of think about it. Down the line.
But again, both those examples, you were underwriting the eventuality of those companies selling and having a liquidity event.
Yes.
So, when Steve came 6 years ago and said, look, Jefferson, told you how big it was, clinical business, academic business. That's old math. New math is clinical pillar, academic pillar, innovation pillar, and philanthropy pillar. At the end of the day, it's still math. There is still the bottom line. So how we see ROI is in three broad ways. One is the clinical impact of the Jefferson Health System, whether that's cost savings or increased revenue, however the clinical pillar sees that. Second, which you can't monetize, but is around building our reputation as being one of the enterprise systems in the country that is really driving forward innovation, like others here. And the third is the financial, what we call the alternative source of revenue, whether it's a liquidity event or something else. That's our ROI.
And you're valuing tons of companies
Yes.
as part of the incubator. When you hear that's a cost-saving business model, how do you feel about it?
It depends on the company. So we, especially when companies are in program in the accelerator, a huge thing we spend a lot of time on is assessing ROI and helping them understand it. I spend a lot of time trying to illustrate the point between soft ROI and hard ROI, and so especially time savings. That's one that a lot of companies come in and they say, we're going to save you a lot of time. And we really have to delve deeply into that to understand, okay, with that time, what are we doing? Are we reducing staff? Because that's real savings. Are we increasing revenue? That's real money. If it's tiny little increments of time that a company comes in and says, over a year we're saving you 2,000 nursing hours, but that doesn't actually translate into we're paying them less or we're removing staff or things like that, that's pretty soft. That's not real savings. So we really try to delve into, okay, how can we find a hard ROI that's either true savings that we're actually going to see in a budget or increased efficiency that leads to increased revenue. But it's very case by case.
I think we have time for one last question.
Yeah,
Sir in the front.
Robert from Sweden. We're working on faster, safer throughput in medical diagnostic imaging, workflow AI solution, but I was actually we're collaborating, we're from Europe, we're collaborating with European hospitals and with Indian hospitals in a co-creation fashion. And it sounds like you're also sort of co-creating when you talk about sweat money and stuff like that. But are you looking at also actually collaborating across hospital systems, healthcare systems, and also, for instance, with European hospitals in co-creation, or you just really want to be sort of the only partner for a startup?
Okay, so for the rest of the audience, the question was, are our health systems interested in collaborating with other hospitals and health systems, or do we work independently with the solutions in our portfolio and are not necessarily collaborative with potentially competitors? So I'll start and then you guys tell me what I said wrong. So I actually organize about 20 hospitals from around the country on a monthly call where we talk about investment best practices and co-investment themes. Some of the people on the panel here are members of that call. Hopefully by the end of this week, they all will become members of that organization. And what's been really helpful for me is actually being able to go to my board and say, This Providence is invested, Cedars-Sinai has in their incubator, and in that case, we're talking about Gauss, which I think 8 of us co-invested in, which is a blood loss management solution, and Hawthorne effect, which Mount Sinai and Cedars-Sinai came together from the beaches and mountains to it's a clinical trial solution. I was just in Europe at the Frontiers Health Conference in Berlin. The business model across Western Europe varies country by country. I find it rather challenging. And what I've noticed is it's easier to work with other strategic investors from pharma and I don't know what you would call it, like Philips or Allianz, some corporate venture on projects together than it is to work with hospital systems, just because I think their revenue model and their mentality is slightly different at the moment, though evolving quickly, and I'm to be corrected on that.
No, I think that's exactly right. If Providence is experiencing this problem, all health systems are probably experiencing this problem, and we're not competitive with all health systems. Like, you guys are in New York, we're on the Western Seaboard. I don't care if they're working with Mount Sinai. In fact, if I'm invested, they better be working with Mount Sinai from my perspective. And we're even co-invested with Kaiser, which is arguably the only one that's really all that competitive in our exact geographies, and we've invested in like 4 of the same companies they have. So the investment side isn't as competitive. It's more around, let's create innovation in this space, because if it's addressing your problem, it can probably address my problem as well.
So we have a different model to that. Because we're very much focused on that co-development, deploy, validate, right? We don't, invest much cash or in many of the companies. We need to have the discipline of our clinical enterprise, and more importantly, the discipline of that company and the focus of that company. These are early stage companies with 10, 15, 20 people. And we tried to do something with another health system in North Carolina where it was a tripartite. So they were rural, we're urban, the company loved it and so forth. It didn't work, right? We were saying something, the other system was saying something else, the company was getting confused, we were getting confused. They didn't have the bandwidth to say, hey, we're going to go all in. And so the other health system in North Carolina actually unwound the relationship, right? And now it's just Jefferson and this company. And so we find that very difficult to work across multiple health systems when we're doing the actual living laboratory stuff. And then just focused on your other question, we work with companies from all over the world. From Israel, we have 2 companies from Finland, we have a company from the UK. So, we're not focused on just looking at the US. And a lot of those kind of European or Israeli companies are already commercialized in those sites, and they want to come to the US, and they want kind of a landing zone to be able to figure that out.
We like to partner where we can. In fact, our first investment, one of the key things we want to be able to do was co-develop. This was brought to us by Northwell Ventures, who is developing. I'm sorry to say that. But they were developing. They were working with this company on a certain application. We were working on other applications. We both had needs, and we actually created some leverage for each other. So it's the kind of opportunity that we would like. And as you said, if you've got a problem, there's a good chance that we've got a problem. I mean, we actually, we were trying to partner with the Cleveland Clinic, who's a mile down the road and who's our fiercest competitor, from a patient standpoint. But when it came to an investment, if we could both lean in, we were going to both win, and it wasn't going to impact either of our abilities to attract those patient populations that we're competing in the marketplace over.
And what is the final word?
I would say partnership in general.
We used to have a partnership.
We used to be better, more integrated. But I would say in general, for us, we think about it is in everyone's best interest for the companies we work with to be as successful as possible. So both because of our investment, but honestly even more so, if we're relying on a solution in our health system, if we've deployed it everywhere, we don't want that company to go under. We want them to be sustainable. So it is very much incentives aligned for us to say, if we like this, we're going to introduce them to as many people as we can and say, look, we use this, we rely on this every day, and you should too, so that we can all benefit from this. So we definitely encourage partnerships, and then in terms of international, similarly, we have international companies that will work with us, and then our hospital has agreements primarily through research and our tech transfer with a lot of international firms.
Sadly, this brings our panel to an end. I have to thank Claire and the team from RESI for being so wonderful to invite us into my incredible panel. Thank you so very much.